So if you are in menopause or perimenopause and you're being told, well, maybe you should take some magnesium or try more melatonin or, keep your room even cooler and it's not working, there are many reasons why. And today I'm going to tell you the reasons why the generic advice for sleep in perimenopause or menopause does not work. It turns out there are 4 types of sleep issues that you might have if you're a woman in midlife. And we're going to be delving into all of that. One thing I want you to know right from now is this, that menopause does not just cause one type of sleep problem. It actually causes those 4 that we're going to delve into. And this is why just giving you a blanket group of advices or one strategy or a list of sleep hygiene tips just doesn't seem to work. In fact, I consider it gaslighting to think that the fact that my hormones are a little bit erratic or a lot erratic and just, dropping the temperature of the bedroom is going to fix it. It is gaslighting as far as I'm concerned. So let's delve into it. I want us to first talk about what are those things that are actually happening. Number 1 is you have your hormones changing, right? Estrogen and progesterone are decreasing, and especially in perimenopause, they decrease and then they increase and they decrease and they increase and they plateau and then they start to decrease as you approach menopause more consistently. And these changes don't just cause one issue, they cause several sleep problems that affect multiple sleep systems, from your brain to the environment to your mood to actual medical sleep disorders. So decreasing estrogen, decreasing progesterone, increasing cortisol impact your sleep in multiple ways and impact different sleep systems. Number 2 is this: estrogen has effects on your brain's what we call thermoregulatory system. So it's almost like your brain's homeostatic system. So it, as a result of that, contributing to the hot flashes, but not just the hot flashes. It impacts your REM sleep, your rapid eye movement sleep. It impacts your sleep architecture, again, causing a specific type of sleep disorders. Number 3 is the progesterone's impact. Now, progesterone, many people call it nature's Xanax. Why? Because it actually acts on certain receptors in your brain called GABA. And what that has to do with is this calming effect that your brain has. So as a result of that, you can imagine if you're low or you're decreasing in the level of progesterone that your body is producing, how that might contribute to insomnia and anxiety and all kinds of things. So in my practice, this is something that I see all the time. I see so many women in midlife and they're told, well, your sleep issues are because of menopause, right? What does that mean? What does that even mean? Well, that to me is an analogy of saying your car is not starting because it's old. Okay, what is old? Is it the battery? Is it the starter? Is it the fuel system? Is it the gear, right? You need an accurate diagnosis to know what effective treatment you need. Again, remember that telling me my car is not working because it's old is not really helpful. I need to know what exactly I need to replace, what exactly I need to support. And the same way with our systems in midlife, in perimenopause and menopause. So let's talk about the 4 different types of sleep issues you might have when you are in menopause or perimenopause. Just as a reminder, perimenopause is around menopause. So don't wait until you're fully in menopause before you realize that sleep issues can have started almost 10 years even before, which is that perimenopause. Is when your hormones initially in perimenopause is kind of declining and increasing. It's kind of like in a roller coaster. And then in menopause, things are really eventually starting to die down, right? So I don't want to wait till menopause. I want us to start to address those issues right during perimenopause. So the first I would say is the fragmented sleep, okay, or the fragmented sleeper. So if you're somebody that has issues with staying asleep, meaning that you fall asleep okay, but you're waking up 4 to 6 times at night, guess what? It's probably related to perimenopause if you're in midlife, especially if you have short wake ups or even if you have longer wake ups. And so, what is going on here? Well, remember, I said with the estrogen changes, your brain is not really helping you to stay in that level of consolidated sleep. So, you're literally going between consciousness and unconsciousness, consciousness and unconsciousness. Your sleep stability is reduced, your deep sleep is reduced. You have a lot of what we call arousals, you have more light sleep. And all of this is because estrogen levels are starting to be low. And we've seen it in research. There's certain stages of sleep where we have what we call sleep spindles being generated. And that's important for memory, consolidated sleep, all of that. So if you have lower levels of estrogen, the way your body might respond in terms of sleep issues may be that you're just having these multiple nighttime wake-ups. And so that is something we got to check out. Another reason why that could be happening is maybe you're waking up because you have sleep apnea, which can also happen as the muscles of your airway start to relax. So why is this important? Well, at the end of the day, if what's going on is multiple wake-ups, me telling you to try to get more sleep is going to probably even make things worse. In a situation like that, I want to find ways to help you to consolidate your sleep. So this is where something like cognitive behavioral therapy may come in. This would be somewhere where things like getting a sleep study to figure out what exactly is fracturing or fragmenting your sleep would come in. This would be a place where, well, considering hormone replacement therapy would come in, because what we're doing is consolidating your sleep, not telling you to spend more time in bed, try harder to sleep, let's take a sleeping pill. Well, that might not be what will address the underlying cause. So that's the fragmented sleep. The second is the sleep issues due to hot flashes, right? So you might wake up multiple times because of hot flashes, but there's a whole different phenotype of sleep disorders that may come up if you have hot flashes. So what is going on? You're drenching in night sweats. You're focusing more on changing your beddings than you are on sleeping. Your temperature is fluctuating and the temperature spike is waking you up, and you're waking up maybe 3-4 times a night. And because of that, you're not able to get, again, consolidated sleep. You're uncomfortable, you're irritable, you feel sweaty. It all is not good. What is going on is this: as the estrogen levels are decreasing, we have what we call vasomotor symptoms. This is a brain activity where you just literally start to have fluctuations in your core body temperature. And studies have shown that 44% of women who have these hot flashes have sleep disruptions. Imagine 44%, almost half of the women. So this is something that we see even in sleep studies. These are not just like, oh, my brain is waking me up. This is pure discomfort because of all these vasomotor changes. So how would we treat that, right? Managing it with cognitive behavioral therapy for insomnia may not necessarily be the key, except if you already, of course, have insomnia as a result of that. Telling you to spend more time in bed may not necessarily fix it. Telling you to drop your bedroom temperature maybe could help, or may not be the only thing you need. In a situation like that, well, I may push towards getting you on hormone replacement therapy, or may push you towards getting non-hormone replacement therapy that helps with hot flashes, such as SSRIs, SNRIs. We have some medications that can help if you're somebody who does not really want to start hormone replacement therapy, or you're not a candidate. And I fully appreciate that. Not everybody's a candidate for hormone replacement therapy. Then things like environmental adjustments, right? So cooling mattresses would be helpful. Moisture wicking fabrics would be helpful, but they're not fixing the issue, right? Looking at certain ways to help you manage those hot flashes to keep things as stable as possible without freezing your bed partner would potentially be helpful, right? So not just telling you, oh yeah, deal with it, or oh yeah, maybe it'll get better, or ignoring it is gaslighting. It doesn't help. And then the other thing we know is these hot flashes, these vasomotor related sleep loss actually have heart implications. They've been associated with increased risk of certain cardiac diseases. So this is not just something that we're addressing because of comfort. This is something that we're addressing because it affects our entire health system. Oh my goodness. If you have not subscribed to this channel, I want you to. This is probably one of the most intense, I would say in a good way, or deep dives that I'm doing into sleep in perimenopause. And I do not want you to only keep this to yourself. So Subscribe, but also share this with me, with the woman in your world. We're going to be talking about number 3 right now. Number 3 are the women who have circadian rhythm issues. Circadian rhythm is, again, that biological clock that tells you when to fall asleep and when to wake up. So these are women who all of a sudden, maybe you used to go to bed at 10, but you realize, like, I'm wide awake at 10. I'm not falling asleep till 12. And these circadian rhythm shifts we see in our kids, in our teenagers, in children with ADHD, in people who are night owls. But because around perimenopause and menopause, we actually start to see a decrease in your body's melatonin, your body clock might actually shift to later. And what I see is women who have a hard time falling asleep. They have a hard time getting out of bed. So they are exhausted. And these are actual age-related changes. This doesn't have to do with you scrolling on social media. So in that case, telling you, oh, just get off social media, it's kind of gaslighting. It's not necessarily what will help. It's understanding that the way your body is creating melatonin is declining because, again, these age-related changes. And these, at the end of the day, can contribute to insomnia, because if you are told, well, I can't fall asleep at 10 p.m. and people don't help you understand this is really related to circadian rhythm issues, and they're like, oh, well, go to bed earlier. Maybe you'll be able to fall asleep. That's going to cause insomnia, because now you're going to be awake, staring at the ceiling, trying to figure out what in the world is going on with you. And in a situation like this, how do we treat it? We're talking about reinforcing the appropriate type of light therapy. So we may do light therapy in the morning, avoid excessive light exposure. In the evening, we may do very low dose melatonin, in which case we're giving like 0.5 to 1 milligrams, and then we're trying to activate you. We do a therapy called chronotherapy. So these are the strategies that we're using: morning light exposure, evening light avoidance, strategic melatonin, consistent wake up time, which is actually more important than your bedtime. These kind of strategies can help with shifting your body clock and helping you navigate this phase. So not going to bed before 10 p.m. when you're not falling asleep till 11, not taking some kind of high dose melatonin or some mega supplement that may potentially even make your sleep worse. Understanding these things is going to be so critical to navigating this. And so you can see why, again, the generic advice is not working for you, because there's so much to these issues. Number 4, I hope you're with me. We're going to talk now about the anxiety-driven insomnia. These are the people who have sleep-related anxiety. As you're approaching bedtime, your mind's already running a mile a minute. You're hypervigilant about your sleep issues. Everything seems to wake you up. Before, your spouse snoring, you couldn't care less, or a little light coming in. Now you're super sensitive to that. You're already thinking, I can't function tomorrow. My mind can't turn off. These kind of complaints is what I hear from women who are suffering from the hormonal changes that contribute to mind racing. So again, progesterone dropping is something that can result in that. And these things can impact your mood regulation. It can impact anxiety. Again, progesterone reduces GABA, which is, again, a chemical in your brain that helps create that calming effect. So when you're lacking in those hormones, your own body is going to create this insomnia loop. It starts to then create, again, this loop where you're in and it's hard to come out of. And the more you think about it, the harder it is to sleep. Now you have this conditioned hyperarousal. You're really not able to sleep. You're frustrated. You're tossing and turning. And in a situation like that, guess what? Again, telling you to stay in bed and try to sleep is not going to work. Telling you to exercise more during the day may be helpful, but may not be curative. In a situation like this, we may consider cognitive behavioral therapy for insomnia. In a situation like this, we may consider hormone replacement therapy, especially progesterone. In a condition like this, we may consider, doing some more evaluation for an underlying sleep disorder. In a condition like this, we may tell you, well, I want you not to try harder. I want you to release sleep-related effort, because the harder it is to try to sleep, the harder it is to sleep. And so this is really how we do it. So let's make things a little more complex. It's not as if you're going to come in and say, I'm type 1, I'm type 2, the hot flasher, I'm type 3, the circadian rhythm insomniac, I'm type 4, anxiety-driven insomniac. Most times you have a combination of all the things. So tailoring what you need to what's going on is even much more critical. I often see women with two things. They may have hot flashes and they may have anxiety, right? They may have a lot of anxiety and they may have circadian rhythm issues. And so just throwing more magnesium is not going to help. Throwing more ashwagandha is not going to help. You need to figure out the actual mechanisms so that we can tackle what's going on. And that's really what we do in our diagnostic practice. We really map out what your sleep needs are. And then with precision, we can tell you what exactly you need. This right here is a game changer. How do we do that? We look at your sleep diary. So we're getting logs. We usually will look if you have an Apple Watch or a sleep tracker. We're assessing it, again, to run diagnostics, not to make you feel bad. Many times we're getting a sleep study because oftentimes women get underdiagnosed with sleep apnea or sleep movement disorders like restless leg syndrome. So we're evaluating that. We are also doing a holistic sleep panel to really see what's missing. What are you missing in your nutrients? What are you missing in your hormones? What exactly is going on? The reason why these are also important is that the risk of these sleep disorders, iron deficiency, sleep apnea, mood disorders, depression, anxiety, multiple fold increase with menopause and perimenopause. So one size absolutely does not fit all. Here's what I want you to start to do over the next few weeks. Start tracking, observing your sleep and saying, okay, what is going on? How do I feel when I'm going to bed? Am I sleepy? How do I feel when I wake up in the morning? Is it difficult? How do I feel when I wake up in the middle of the night? Is my mind racing? And you're going to start to see some patterns which will clue you into maybe this is a little bit more than something that a sleep supplement can do. The next step I want you to do is make sure you're matching the right intervention to the right sleep pattern. Do not use generic protocols. This is where seeking the help of an expert comes in. And you can see a menopause expert. You could come see us at the Restful Sleep Place because we will help you narrow these things down. You could speak to your primary care doctor because at the end of the day, severe daytime impairment may be because you're dealing with a sleep issue that's not being addressed. And if you're out there, you're freaking out or you're worried or it's not working, you're throwing everything, including the kitchen sink, and it's not getting better, I want you to know that you are not alone. This is what we do. This is why we exist, literally, at the Restful Sleep Place, to make sleep better for you. So if everything you've done is not working, it's not to do more of what's not working. We specialize in sleep health for women in midlife. And we would want you to come join our practice, visit us. Let's help you figure this thing out. Let's help you move from drained and exhausted to thriving and living your fullest potential. And how do we do that? Well, just visit our website, therestfulsleepplace.com, and we'll be more than happy to get you started on this journey. So I hope this has been helpful. I know it's a little longer, but I just wanted to get this out there to you so that you know that you're not alone. There's help, there's hope, and we're here for all of it. Until next time, I hope you rest well.